Do start. Live? Huh? Students हैं? है कर देते हैं यार स्टार्ट. हाँ चलो है ना, ठीक है. नहीं स्टूडेंट्स हैं? कहाँ पे दिखाई देगा बताओ मुझे. कहाँ पे दिखाई देगा बताओ मुझे. हाँ कर दो. नहीं तो स्टार्ट करूँ. Okay. So good morning everyone. So this class is primarily on three subtopics of pediatric neurology and development. So intellectual disability, attention deficit hyperactivity disorder and learning disability. Now the thing is that previously this lecture was restricted to two topics, ADHD and LD, that is attention deficit hyperactivity disorder and learning disability. But this time I have seen that a third topic has been added in the same lecture, so it will be three topics, more of a horizontal discussion on these three, and at your level, at undergraduate level, it is more important to understand the concepts rather than know these things in detail. Now why these three have been clubbed together is that most of the children who would come to us, in our outpatients or wherever, some parent would come and tell us that my child is not performing well academically. So these are the three things that should come to our mind, that is intellectual disability, attention deficit hyperactivity disorder and learning disability. We need to differentiate between these three because all of them have different therapeutic implications. Whereas in ID, that is an intellectual disability, some of the cause may be treatable, some may not be treatable. On the other hand, ADHD and LD are actually remediable to a significant extent. So it is very important that these three things we are able to differentiate, we are able to identify and then act accordingly so that there is improvement. To start with, when we say intellectual disability, it's a very basic concept that below 5 years of age, we call the same thing developmental delay. And beyond 5 years of age, we call it intellectual disability. So how they're different from each other, those things would become apparent as I start the lecture. So we'll start from development so that there is a flow from developmental delay to intellectual disability. Then we'll move on to ADHD and then we'll move on to LD. Okay, so development is an integral part of health assessment in childhood. As you have seen in all your history taking, there is a separate heading for development. It indicates both physical as well as mental growth. Routine surveillance is mandatory because you need to appropriately refer and intervene. And as we all know that if there is an early and appropriate intervention, there is attainment of best developmental potential. Now these are the patterns of development. This is a child who will have a normal development. Now this line shows a development which is happening but at a pace which is slower than the normal development. So this is actually how a developmental delay looks like, also called static encephalopathy. Now if you look at this, there is a development which is delayed to begin with, but the child is gaining milestones and then subsequently starts losing whatever he has gained. This is regression. You can also have this waxing and waning which is seen in static encephalopathy and developmental delay. Some gain, some rapid gain, then some plateau. So if you are gaining at normal pace, normal development, if you are gaining but at a pace which is different or slow from normal development, it is developmental delay. And if you regress, that is you gain to a certain point and then you start losing, it is regression. Now what are the causes of pseudo-regression? There could be increasing spasticity, there could be a new onset movement disorder, there could be new onset seizures, there could be side effects of drugs that that the child is receiving. It could be a hydrocephalus, so it could be a parental misconception of attained milestone. So when we say pseudo-regression, we mean in a condition which would cause developmental delay or static encephalopathy, what all can cause regression of acquired milestones? So these are the causes. Now moving on to the domains of development, it can be gross motor, fine motor, language, socio-cognitive, vision and hearing. I'm not going into the details. Why it is important to understand development is that unless and until we understand developmental delay, we won't be able to get the concept of intellectual disability. So these we have been dealing on a day-to-day basis with you in your clinical postings as well as outpatient postings. So I'm not going into the detail, but you should know that these are the domains of development. Now, when we say a domain-specific delay, we mean that there is a particular domain which is affected. Now, there should be a detailed developmental history in chronological order, which you all are aware of. Then we need to screen other domains. There is a detailed objective assessment of affective domain. And then we understand the pattern of development. It is static or improving. It's a regression or a plateau. Then what is the age at onset of the delay? Because that will tell us the disease process. Now, what are the developmental patterns? As I've already told you, you can have a normal, orderly and sequential within accepted temporal range limits. You all are aware that these are the developmental milestones and these are the age at which they are supposed to be attained in a child, and that's a normal development. On the other hand, delay is significant lag in one or more areas of development. They are objectively assessed by using developmental quotient or intelligence quotient, as you can see, or, and it is primarily depending on the age at which the child is being assessed and what scale we are using to assess the child, which has to be individualized depending on whether we'll be able to run a test which tells us DQ in a child or IQ in a child. At its simplest, it refers to lag in attaining milestones as compared to children of same age. So this is the importance. What is development quotient? So this is suppose I want to see just the gross motor development quotient. This is an individual domain. So what is the developmental age in gross motor domain divided by the chronological age into 100? What is the development quotient otherwise? It's a mean development quotient divided by general development quotient. Now it is mostly used in infants or preschool children. It's a numerical indicator of child's development across a range of psychosocial competences. Now before we go beyond, I just want to tell you certain things like, when we say development quotient, we basically would come out with it using an objective assessment scale. Now I'll talk about the objective assessment scale later, and if we are calculating it beyond 5 years, we come out with what we call IQ, the intelligence quotient. It is the same, the intelligent age divided by the chronological age. Intelligent age is the skill which the child is able to perform best. What is the age equivalent for that? Divided by the chronological age of the child into 100. Now what is important is that till 5 years of age, we have defined milestones that a child has to attain, say running. But beyond 5 years, you don't have any other milestone, like a child cannot do anything beyond running, right? So in that situation, what we do is, we see how the child uses these milestones and applies them in his or her day-to-day activities, be it academic, be it routine activities of daily living. So when we apply the application of milestones and come up with a quotient, it is intellectual disability or intelligence quotient beyond 5 years of age. Below 5 years of age, what we see is just according to the developmental milestones. Application of milestones in activities of daily living and academic spheres beyond 5 years, intelligence quotient. And there are specific objective tests using which we calculate these. Now what is a global developmental delay? So global developmental delay is 2 or more domains are affected. That's a global developmental delay. So what were those? Gross motor, fine motor, language, social. Remember, vision and hearing are not developmental domains, but we need to talk about them to say that rest of the milestones, they are actually delayed, or it is a vision or hearing impairment which is causing the delay. So a visually impaired may have motor delay. A hearing impaired may have language delay, but there is no problem with language or motor skills. So we need to know vision and hearing, but the domains are 4: gross motor, fine motor, language and socio-cognitive. So 2 or more of them affected, it is global. If the delay is restricted to a single domain, it's a single domain delay. So you can have a gross motor delay like we see in neuromuscular disorders, or you can have a language impairment as we see in autism spectrum disorder. So autism spectrum disorder is there is sufficient impairment in social interaction, communication, and there is restrictive repetitive behavior. So we diagnose what is known as a autism spectrum disorder. Now, as I was stressing, the word GDD is usually reserved for younger children, that is less than 5 years of age. The word intellectual disability is applied to older children when IQ testing is more valid and reliable beyond 5 years of age. So the word ID that is there for today's topic is actually nothing but if we are finding the cause of developmental delay beyond 5 years of age, that is a intellectual disability. Developmental delay based on developmental milestones. Intellectual disability based on use of these developmental milestones in our day-to-day activities and academic activities. So a disability characterized by significant limitation both in intellectual functioning and in adaptive behavior as expressed in conceptual, social and practical adaptive skills. So this is the definition, but what we need to understand is it is actually the application of the acquired developmental milestones. It originates at an early age, less than 18 years. So onset before 18 years causing this kind of a pathology is known as intellectual disability. So there are certain developmental patterns which we need not know at this point of time, may not be relevant to this lecture, but just a brief introduction. What is dissociation? Dissociation is when the rate in acquiring milestones is subsequently different in various domains. So if you can have somebody like, for example, say cerebral palsy, you may have a child who has more affection of motor milestones and less affection of language and socio-cognitive. So there is a dissociation. Similarly, in autism, you have near normal motor milestones but significant delay in language and socio-cognitive spheres. So again, a dissociation. Moving on to deviance. So deviance is basically atypical development within a single stream out of a sequence of attainment of milestones, not necessarily abnormal. So just giving you an example is, suppose many of us, if we go and ask our parents, we may have skipped a few milestones. Like some of us may have straight away stood and started walking and would have never crawled. So this is not necessarily abnormal. This is a normal deviance. On the other hand, if somebody has a perinatal stroke, so they may have an early hand preference. So if there is a left hemispheric stroke, the child may actually appear left-handed from the very beginning because there is right-sided hemiparesis. So this is a developmental deviance, early-handedness, which is pathological. Now, when we say developmental assessment, we basically mean under three headings. One is surveillance, one is screening, and one is evaluation. So let us understand. So surveillance is a flexible, longitudinal, continuous and cumulative process whereby knowledgeable healthcare professionals identify children who may have developmental problems. To give you an example, suppose a child comes to you in the OPD for vaccination. You will ask the best acquired milestones at that age, and if the child is fine, suppose at 9 months for measles, the child is fine, you will reassure the parents and send them home. Now suppose at 9 months you find that the child is not sitting with support, which is a delay. So you feel there could be a developmental issue, and then you do a screening. So a screening is administration of a brief standardized tool aiding the identification of children at risk of a developmental disorder. So it is not diagnostic. Simply because on surveillance you have found something which is not appropriate, you have tried to screen it using various screening tools. Now AAP recommends screening at 9, 18 and 30 months otherwise as well. AAP is American Academy of Pediatrics, but this is not diagnostic. Diagnostic is when we do a detailed developmental assessment. So there are validated scales which are socially, culturally, ethnically, geographically validated, and once we use them in appropriate settings, we come up with a development quotient. So it is aimed at identifying the specific developmental disorders or disorders affecting the child. So this is completed in children who do not pass developmental screening, and it is coupled with medical evaluation, and it's called diagnostic. So we do surveillance. Anything wrong on surveillance, we do a screening. And on screening, if anything found inappropriate, we do a detailed developmental assessment using validated scales. So we need to understand what is surveillance, what is screening, and what is assessment. Now, this is developmental surveillance. It's a longitudinal process, right? This is developmental screening. It's happening at each of these. So this is I already have talked about. So what is important is, you need to talk to the parent whether they have any concern about their child's development. If they already have an elder child, they may be actually able to correlate and say that no, things are fine. Then our developmental history, whether compared to previous visit, the child has undergone some sort of change in last 2 or 3 months. Then accurate observations. While you are talking to the parent, you need to make accurate observations of the child, how the child is walking, how the child is holding on to things, how the child's behavior is. So all these things will also give you an idea. And then in the process of your medical evaluation, as I said, developmental assessment coupled with medical evaluation, environmental, genetic, biological, social and demographic factors. Now child with established risk factors, suppose you have a child with perinatal asphyxia, so may be referred directly for evaluation or more frequent developmental surveillance. So developmental screening, as I said, applied to asymptomatic children. On surveillance, somebody found something we find not appropriate, we do a screening. And if the screening is also inappropriate, we refer the child for a complete neurodevelopmental assessment. Early assessment, early stimulation, early rehabilitation, and early detection of benefits. So this I have already told. Why screen? Early identification identifies children at risk. Early intervention services can be planned, and if there are comorbid developmental disabilities, they can also be identified. Remember one thing, when we are talking about developmental disability, a child with intellectual disability may have associated hyperactivity, inattention, so may have seizures, may have hearing impairment, may have vision impairment. So we need to understand all these comorbidities and rehabilitate appropriately so that the child can attain his or her maximum potential. Now, these are some of the common conditions for a child at risk. So we may have prenatally maternal history of inborn error of metabolism, infertility, abortions, any placental disorder, intrauterine infections, drugs, malnutrition, multiple pregnancy, endocrine disorder in the mother, chromosomal abnormality in the child, perinatal. At birth, you can have, hypoxia, hypoglycemia, neonatal jaundice, intracranial hemorrhage, small for dead babies or low birth weight babies. Postnatal, there could be brain infection, metabolic disorder like hypoglycemia, some trauma, some drugs, malnutrition, emotional deprivation, and definitely neurometabolic genetic disorders which have onset in the postnatal period are also causes for developmental delay, which may later make a child intellectually disabled. How to screen? We are all aware, we know all the developmental domains, what are the salient ones which we need to ask. We take a developmental history. We have developmental screening tools, and as we all know, how do we take a developmental history? We look at the developmental trajectory, we talk with the parent, we'll compare it with other children or with established norms, and also we look at regression autistic traits and comorbidities. The history is incomplete without a 3-generation pedigree, because that will give you a hint whether it's a inherited or a genetic disorder. Then history of prior gestation, pregnancy losses, early neonatal infantile deaths, consanguinity, ethnic heritage. So all this would give us an idea whether it's a genetically inherited disorder. Antenatally, if you remember the table, the chart that I showed you for causes, automatically you will know what all to ask. Proper antenatal care, any obstetric illness like PV bleeding, gestational diabetes mellitus, PIH infections, any maternal drugs, alcohol, tobacco, illicit drug abuse, poly or oligohydramnios, and fetal movements. So fetal movements usually come at around 16 to 20 weeks. If there is a reduction in fetal movements, there could be some amount of hypoxia, there could be neuromuscular disorder. If there is increased fetal movement, it could be or progressive encephalopathy. You all are aware, static is there is gain but at a lower pace, or a waxing waning. Progressive, there is a gradual loss of milestones. What is the developmental level in each domain, which means developmental age in each domain. Current rehabilitation and social status. So a child who is 9 months old, the best acquired motor milestone is neck holding. Then the developmental age is 3 months, because that is the age correspondence for neck holding, and the chronological age is 9 months. And then taking all the history for etiology, maternal, child, developmental domains, comorbidities, we should be able to get a fair idea of the possible timing of the insult. Physical examination, this we are all aware. Just remember one thing, when we are doing a developmental examination and we are carrying a developmental kit, it is always important to give the kit at the very beginning, because if you expose the child to all the components of the kits at the very beginning, even before you start taking the history, on one hand you can go on taking your history, on the other hand you can observe the child how he is using the various components of developmental kit, and that will also give you some idea of the developmental examination. Now rest of the things are the usual prerequisites for any pediatric history taking and examination. So anthropometry, head shape, any dysmorphism, it could be a Down syndrome, neurocutaneous marker, it could be neurofibromatosis, you look at cafe au lait spots. The spine could be associated kyphoscoliosis, any organomegaly, could be a storage disorder. Eye evaluation could be optic atrophy, cataract, retinitis pigmentosa, hearing assessment, a detailed neurological assessment, and neurodevelopmental assessment. So some common examples, this is a child with Down syndrome, then this is as you can see various facies. So this is again a child with cleft palate and cleft lip. This is a child with mucopolysaccharidosis. Then this is short stubby fingers. So this single seminar palm and crease. So these all help us in finding clues to the underlying etiology. So dysmorphism, various facies will tell us that the child has an underlying chromosomal or genetic disorder. Other defects, this is like a holoprosencephaly. So two lobes of the cerebrum is fused. So you then have sets of differentials. So all this becomes important. So this is a midline problem. So that is why there is cleft lip, cleft palate and fused cerebral hemisphere. So this becomes one disorder. So looking at the face, looking at the body structures, looking at the joints, you may get a hint what could be the underlying disorder. Then these are various neurocutaneous stigmata. So this can be seen in tuberous sclerosis, Ashliff maculopapular lesions. This is retinitis pigmentosa. This is café au lait macules in neurofibromatosis. This is again in tuberous sclerosis, what we call Sjagren patch, that is orange peel consistency. This is again Ashliff patch. So what I'm trying to tell you is that if we do a good general physical examination, look at the face, do a detailed eye examination, look at the skin, many times straight away we may get a diagnosis. So that is why it is so important to do a detailed general physical examination in a child with developmental delay or intellectual disability. Moving on, these are incontinenti pigmenti. Then you can have this port wine stain. Port wine stain which is seen in Sturge-Weber syndrome. So, and this you see as a corresponding meningeal calcification that is seen in Sturge-Weber syndrome. So again, CT, MRI may not be available at the beginning, but just looking at the skin, see how much information we are getting, and we can straight away reach to the diagnosis of a child with developmental delay or intellectual disability. Eye examination, why so important? So if you have cataract, think of galactosemia, intrauterine infection. Then if you have a dislocated lens, think of homocystinuria. If you have a cherry red spot on your fundus examination, think of storage disorders like gangliosidosis, Tay-Sachs disease. If you have chorioretinitis, think of IU infection. If you have retinitis pigmentosa, think of mitochondrial disorder. So what I'm trying to say is, again, if you have understood skeletal deformities, skin deformities, facial dysmorphism, eye abnormalities could actually give you the diagnosis in a child with intellectual disability. Plan your treatment accordingly, plan your rehabilitation accordingly, and also help in prognostication. Now, this was, a series which is from various global studies. So what you can see is that of all these studies, this is the number of children with developmental delay or intellectual disability assessed. By history and examination, the yield can go up to 73%. So this is actually an Indian study by Johari et al. And up to 73% can be identified just by history and examination alone, which is a big percentage. So there lies the importance of a detailed history and examination in a child with developmental delay. So this is study from our own center done by our seniors Madhulika ma'am, Shifali ma'am. So if you see that the highest etiology in Indian scenario is an HI sequelae, a dysmorphology syndrome, Down syndrome. So again, if you see, if we are able to do a good physical examination, good history taking, we'll be able to identify a lot of them. So what are the various screening tools? So at your point, you should just know DDST, that is Denvar's developmental screening tool, which is the commonly used screening tool globally that is being used. Individual domains, you need not know. Objective assessment tools, very important. Objective is developmental evaluation. So we have what is called developmental surveillance, that is our history taking. Screening tool, you can remember DDST. And then for developmental assessment, we have DASI, developmental assessment scale for Indian infants up to 30 months. BKT, it's a Binay Kamath, 2 to 15 years. MISIC, Mallin's intelligence scale for Indian children, 6 to 15 years. So this actually gives you IQ. This also gives you IQ, but this gives a DQ, because if you look at the upper range till which it can be used, you can understand whether it can give you just DQ or DQ as well as IQ. This cannot give you a DQ because it is more than 5 years. So till 5 years DQ, beyond 5 years IQ. So now just a simple thing, this you should remember. So anything that is above 90 for an IQ or a DQ, it is normal. 70 to 90 is borderline. 50 to 70 is mild. 35 to 50 is moderate. 20 to 35 is severe, and less than 20 is profound. Now these are some practice tips. So what is a corrected age? So because when we are looking at the developmental domains, we need to know the corrected age of the child. So the age of the child since the expected date of delivery. So suppose a child is born at 28 weeks. premature child, and then you're seeing the child at 36 weeks. So the corrected age is, and you're seeing the child at 8 weeks postnatal. So the corrected age is 36 weeks. The correction for gestational immaturity at birth should be done till 24 months of age, because on one hand, when the child will just reach 40 weeks, you will think that the child is 3 months old and why the child is not holding his neck. But the fact is that he's only 40 weeks. So at 40 weeks, no baby will have neck holding. So that is why you need to know corrected age. That is, what is the post gestational age. So that is very important. So 28 weeks born and 40 weeks born. At 3 months of life, both will be 3 months, but 40 weeks would be 52 weeks and 28 weeks would be 40 weeks. So automatically the child who is 52 weeks will have certain milestones. The 40 weeks child will not have those milestones. So we need to do these corrections when we are looking at development. So growth, developmental milestones and initiation of complementary feeds is all according to corrected age. However, postnatal age is used for immunization. So whether a child is born at 28 weeks or at 40 weeks, at 6, 10 and 14 weeks, they'll have their routine vaccination. So for the 28 weeks, it will be 34, 38, 42 immunization. For 40 weeks, it will be 44, 48, 52. That will not change. But for calculating development, for calculating anthropometry and for initiation of feeds, we need to look at corrected age of a premature child and then introduce these concepts. So this is just a simplified flow diagram. So if you have isolated delays, if it is motor, you think of CP or cerebral palsy or spinal cord lesions, lower motor neuron, you think of neuromuscular disorders. It could be chronic systemic illnesses, skeletal abnormalities like rickets, skeletal dysplasia. If you have isolated speech delay, it could be hearing impairment, it could be autism spectrum disorder, it could be speech delay. If you have cognitive delay, it could be intellectual disability. In poor academic performance, consider SLD. I'll be coming to that, specific learning disability. If there is a global developmental delay, you think in terms of dysmorphism, you think in terms of motor impairment, regression, and then you think about hypothyroidism and chronic systemic illnesses. So just to make it simple, less than 5 years, developmental delay. More than 5 years, intellectual disability. Developmental delay based on attainment of milestones. Intellectual disability based on attainment of milestones and their application in day-to-day life and our academic spheres. Then detailed physical examination, detailed history taking may solve our etiology problem in most, which will help in proper identification, proper diagnosis, treatment, management, rehabilitation and prognostication. And we also need to know what value is normal for IQ or DQ and what values then would fit into a child into a particular category, which I just mentioned. And apart from that, what we need to know is what is developmental screening, what is developmental surveillance, what is developmental assessment. So now moving on to the next topic. So I think you have understood what is intellectual disability. So now moving on to the next topic. Now just before we go on to ADHD and LD, which would be shorter, just briefly on the role of investigations in intellectual disability. So neuroimaging, MRI brain is the modality of choice. It is particularly helpful when there is abnormal head size or there is associated focal deficit. So just understand that MRI brain is an important modality. Metabolic testing, we need to look at inborn errors of metabolism. If there is recurrent encephalopathy, vomiting, seizures, regression of milestones, organomegaly, cataract, retinopathy, you might have got some idea from the slides that I showed you previously. Genetic studies, as you saw that there could be a lot of genetic causes, so we may have to use and choose appropriate genetic investigations. Now, in clinically relevant cases, we need to do thyroid function tests, blood and urine lead levels, serum micronutrient levels in clinically relevant cases. As you saw that hypothyroidism is a common cause of developmental delay. Then EEG, if we think of seizures, vision and hearing assessment should be done. If we are suspecting neuromuscular disorder, we may have to do nerve conduction studies and electromyography. Some common, CT scans, this is cortical atrophy. If you see, there's a lot of, the gyri are separated and the sulci spaces are prominent, which says that this is an atrophy. This is a CT head showing the periventricular calcifications, this hyperdense white structures on CT scan. You can see this in periventricular area, white matter abnormalities seen in preterm brain injury. You can see again on a CT intraventricular hemorrhage within the ventricles, you can see these hyperdense structures. And here you can see that one side of the hemisphere is fine, the other side of the hemisphere is atrophied and there is prominence of the ventricles. Okay. Now this is cerebral malformation. You can see that the gyri are incompletely formed It's more like a smooth cortex called lissencephaly. This is what we call the hemimegalencephaly. Just look at this side. You can hardly make out, just see here, it becomes more. There are no gyri, no sulci. This looks huge. The ventricle is not visible properly. So this is a hemimegalencephaly. And this is a schizencephaly. So there is a cleft which is lined by gray matter of CSF. So these are various cortical malformations. So this is how imaging would help us in knowing the cause. Metabolic testing, this would include blood gas, lactate, ammonia, organic acids, amino acids. You just need to understand, as I just said, what are the indications for metabolic testing, and these are the routine metabolic tests that we do in a relevant clinical scenario. Genetic studies, depending on, if we don't find a recognizable cause and we expect that the involvement will be greater than 5 MB, we would go for karyotype. If it is 1 to 5 MB, we would go for fish. If it is less than 1 MB, we would go for chromosomal microarray. There are specific genetic mutations like Fragile X, Rett syndrome, tuberous sclerosis. So if we look at the child and we are able to make out that this is the syndrome, then we can straight away go for a genetic mutation. And management of ID requires a multidisciplinary care where you have a pediatric neurologist, you have social workers, psychologists, psychiatrists, nutritionists. Physiatrists are rehabilitation experts, ophthalmologist, ENT, audiologist, and speech therapy. So it's a multidisciplinary care which is useful in a child with intellectual disability. Now moving on to the next topic for today, that is attention deficit hyperactivity disorder. So just understand ID, and now the second topic is ADHD. So what is the epidemiology? So ADHD is the commonest neurobehavioral disorder of childhood. According to an Indian study, the prevalence has been estimated at 1.3 per thousand, and worldwide up to 3 to 5% of school age children can have ADHD. So what is the definition? It's a behavioral and neurocognitive condition characterized by developmentally inappropriate and impairing levels of gross motor overactivity in attention and impulsivity. Now why it is important to understand the word developmentally inappropriate? What could be developmentally appropriate level of hyperactivity in attention and impulsivity at 3 years will not be appropriate at 6 years. So at 3 years you're not going to diagnose a child ADHD based on certain features, but at 6 years based on same features you will be able to diagnose a child as ADHD. So that is why that hyperactivity, impulsivity and inattention that is seen in the child to label as ADHD has to be developmentally appropriate. So what are the early pointers? So there will be a lot of motor restlessness. There will be difficulty in toilet training. The child will engage in a lot of destructive play, breaking toys, argumentative and excessive temper tantrums, excessive demand for parents or teachers' attention, seem to hate waiting and get bored easily. So at 2 to 3 years, 4 years, these may be seen in certain children, may not be seen in a lot of children. So if we start seeing them, we should, our threshold for assessing them should be very, very low, because we have to understand that they may actually develop ADHD in future, and early intervention in ADHD goes a long way in attaining optimal potential in these children. Now, what is the diagnostic criteria? So the diagnostic criteria is based on DSM-5, that is Diagnostic Statistical Manual. So this is used for, consensus expert based criteria, and they go on upgrading every few years. And so currently it is DSM-5. 5 is Roman, which is being followed. So there are 3 domains which we have to understand in ADHD: inattention, hyperactivity and impulsivity. So I'm starting with inattention. So in inattention, there are 6 or more of the following symptoms of inattention have persisted for at least 6 months to a degree that is inconsistent with developmental level and maladaptive. Very simple. 6 or more of the symptoms, 6 months or more persisted, and it is developmentally inappropriate. What are those symptoms? So just look at these. I'll just go through them so that you understand. You don't have to remember them, but this gives you an idea about the illness. Fails to give close attention to details, makes careless mistakes in school or homework, difficulty in concentrating while playing or doing his or her homework, trouble paying attention when somebody is talking, does not follow the instructions, and is not able to complete his or her work because of these behavior. Difficulty in organizing tasks like doing homework, getting ready for school, putting toys back to their place. So this will not be appropriate for somebody who is 3 years, but will be appropriate for somebody who is 6 years, 7 years. Avoid activities that require sustained mental efforts. Often lose many things. They lose books, pencils, toys. Very easy to get distracted. And forgetful in daily activities. Will forget bathing. Will forget, say, wearing socks and start going for the school. So these are the various questions under inattention. So 6 out of these, if fulfills, the child will actually fulfill the inattention criteria. Hyperactivity, impulsivity are clubbed into one. 6 or more of the following symptoms persisted for at least 6 months to a degree that is inconsistent with developmental level and maladaptive. So these are the hyperactivity. So combining hyperactivity and impulsivity, you need 6 or more, and they are one domain. Look restless, they're moving hands and feet, twisting the body when seated, leaves the class and just roams around, runs about, climbs excessively in places where it is inappropriate, climbing onto the desks in the classroom, is unable to engage quietly in play. You have to always remind them that you have to walk, you don't have to run, because they're most of the times running. It is difficult to control their activities in social places, like grabbing objects from shop in the market, then in friends, relatives' house. So all these things are important. Talking excessively. Then impulsivity. Impulsivity is like they would start answering even before they are asked a question. Difficult for them to wait for their turn. They interrupt others' conversations. So as you see, these are very subjective questions, but 6 out of the initial 9 in inattention, 6 out of this 9 in hyperactivity, impulsivity, and they get categorized into these type of ADHD. So what is the diagnostic criteria? Some hyperactive, impulsive or inattentive symptom that cause impairment were present before the age of 12 years. So the onset has to be before 12 years. It is seen in 2 or more settings, at school as well as at home, at work as well as at home. A clear evidence of clinically significant impairment in social, academic or occupational functioning. So as you see, there is a lot of subjectivity. So this is kind of semi-objective. You have some criteria, they fulfill the criteria, and then as a clinician you take these calls whether these things are happening, and then you label the child as ADHD. And remember, an ADHD child is not necessarily intellectually disabled. In fact, I'll just come to that. So a comorbid diagnosis with autism spectrum disorder is allowed. So a child with autism may have ADHD. A symptom threshold has been made for adults to reflect the substantial evidence of clinically significant ADHD impairment, with a cutoff for ADHD of 5 symptoms instead of 6 required for younger persons, both for inattention and for hyperactivity, impulsivity. So suppose you are seeing an adult, even 5 would fulfill into ADHD. You are seeing somebody who is a child, 6 has to be fulfilled. And the age at onset of these symptoms have to be before 12, and they have to be developmentally inappropriate. So what I was trying to say is, so diagnosis of ADHD cannot be reliably made in children younger than 6 years of age. Hence the consensus clinical criteria should be applied only to children aged 6 years and above, because then you are sure that this is developmentally inappropriate. All the criteria must be fulfilled to make a diagnosis. So this is how it is. You have 30% which is inattentive, you have hyperactive, impulsive, which is around 9%, and then you have combined with all 3 together, inattentive, hyperactive, impulsive, which is around 61%. So the combined type is commonest. So, and the other important thing is, they usually have an IQ of more than 70. So if you have somebody who is intellectually disabled, you won't be able to label that person as ADHD, because he is already developmentally inappropriate. He is ID, so you cannot label as ADHD. So for labeling somebody as ADHD, it has to be developmentally inappropriate behavior. Okay. Now ADHD comorbidities, specific learning disability, we'll come to that next. Other behavioral problems like defiant attitude, hostile behavior towards authority figures, conduct disorder, anxiety, depression. Many of them may have epilepsy. Many of them may have motor and vocal tics with onset before the age of 18 years, commonly seen in Tourette syndrome. What are the differential diagnoses? Many vision and hearing impairment children who have mild vision or hearing impairment can be inattentive, can be hyperactive, can be impulsive. So that needs to be ruled out. Associated behavioral disorders like conduct disorder, oppositional defiant disorder, learning disorder, epilepsy, psychosocial stress, side effect of some drug, the environment at school or home is not appropriate, age appropriate hyperactivity. So we need to know that these are the differential diagnoses, and while assessing a child, we need to keep these things in mind. So what are the implications of early diagnosis? So they, compared with peers, these children, they do less well in school and in the development of social skills. It stops them from focusing on a single task. It disrupts their schoolwork. It makes them fidget, talk excessively, and associated with ADHD and continue into adolescence. And some of them may get into bad habits of, drug addiction, then criminal bent of mind, delinquency. So we have to be vigilant. So have high rates of delinquency, more likely to be arrested than non-ADHD teenagers, at high risk for substance use. So at the risk of injury, because they are so impulsive, they may have, road traffic accidents, trauma injuries are significantly more in these children, as I just told you. So the laboratory investigations, thyroid functions. Thyroid, children with hypothyroidism may have features of inattention, hyperactivity, may have even hyperthyroidism. So we need to look at these features like cold intolerance, constipation, short stature in a child with ADHD. Blood level, lead level estimation. Again, like ID, we need to look at this. Serum iron status to rule out iron deficiency. A lot of children with ADHD may have coexistent iron deficiency, and once iron deficiency is corrected, their symptoms also improve. So when we say thyroid, blood lead and iron, so these are important in ID as well, because these are reversible causes. You treat them, the symptoms would improve. So we need to look at hypothyroidism, we need to look at lead toxicity, we need to look at iron deficiency in these children. Management consists of behavior and psychological management, pharmacological, and management of associated problems and comorbidities. So pharmacological treatment, stimulant medication like methylphenidate, norepinephrine reuptake inhibitors like atomoxetines. So these are important because in ADHD it has been seen that the neurotransmitters primarily affected are the dopamine, norepinephrine, serotonin. So if you're able to target these neurotransmitters, we'll be able to alleviate the symptoms to a significant extent. But what is important is that this has to go hand in hand with behavioral therapy. Just mere pharmacological treatment will not help if you're not giving behavioral therapy. Behavioral therapy not responding, you add pharmacological treatment and it may start showing improvement. As I just said, so the rule of the thumb is, if you have inattention, the stimulant medications help. If you have impulsivity, hyperactivity, atomoxetine helps. Reinforcing positive behaviors, social skills training, providing distraction-free environment, adapting tasks to the child's abilities. So these are some of the adjustments that even the interventionist has to do, but then it goes hand in hand. Pharmacotherapy, behavioral interventions, cooperation from the child, the family and the interventionist, and the child starts showing improvement. So associated problems, comorbidities, specific learning disability, will be coming to that topic in a few minutes from now. So one of the commonest comorbidities need to be managed. Oppositional defiant behavior. So you have behavioral modification techniques and management. Conduct disorder, again behavioral modification. Anxiety, depression, epilepsy, Tourette syndrome. So as I enlisted all of them as comorbidities, so all these comorbidities have specific therapy plan as well. So apart from giving therapy to the child with ADHD, be it a stimulant medication or a norepinephrine reuptake inhibitor, along with behavioral therapy, we need to look at these comorbidities and manage them as well. So high index of suspicion, early identification, we need to refer because it has far-reaching consequences. Early intervention leads to significant improvement. Okay. Now, family support is very important. Multidisciplinary care, helping the family, the disruptive behavior in the child may bring a lot of familial discord, disharmony, blame games. So we need to, counsel the family as well. Parents need to be taught coping techniques. Now, coming on to the third topic for the day, that is specific learning disability. So as you can understand, ID, yes, the parents may come and tell you, my child is not performing well academically. ADHD, the parents may come and tell you, my child is not performing well academically. But the two conditions are different, etiology is different, treatment is different, diagnosis is different, but the complaint may be same. So the third complaint, the third condition for which the parents can again come with the same complaint that my child is not performing well academically is specific learning disability. So what is specific learning disability? It's a group of neurodevelopmental disorders which manifest as persistent difficulties in learning to efficiently read, which is dyslexia up to 80%, write, dysgraphia, or perform mathematical calculations, that is dyscalculia. Remember again, like ADHD, these children have normal intelligence. You all have seen the movie Tare Zameen Pe, in which you saw that the index character was excellent in painting. So a child who has intellectual disability won't be able to paint that well. So they have normal intelligence, they go to conventional schools, they have intact hearing and vision, and they have adequate motivation and socio-cultural opportunity, but there is some problem in their processing of sounds, of visual stimuli, of arithmetic symbols, and that is why they are not able to do this properly. So the defect is processing rather than any direct anatomical or motor defect. So one of the following for at least 6 months despite intervention that target that difficulty. So if somebody comes to you with these problems, you first need to give an intervention. You need to see what happens in those 6 months and then you label the child as SLD. So they are inaccurate or slow effortful word reading, difficulty understanding the meaning of what is read, There are difficulties with spelling, there are difficulties with written expression, difficulty mastering number sense, facts or calculations, difficulties with mathematical reasoning. So some of them would fulfill into dysgraphia, would fulfill into dyslexia or dyscalculia. So again, you need to understand that there could be a lot of comorbidities. The comorbidities are common with ADHD. You can have obsessive compulsive disorder, Tourette syndrome, epilepsy, ADHD, dyspraxia, where there is fine and gross motor coordination problem. So what are the common symptoms of dyslexia? Strongly dislike reading aloud because they feel embarrassed, often confuse right and left because they have difficulty processing symbols. Dislikes dialing numbers on phone and reading text messages, again because they have difficulty in processing numbers and alphabets. Difficulty taking notes when someone is speaking, difficulty in processing what is being written and at the same time to write them. Lose place when reading because they would just lose the line because the lines seem to merge together. They are not able to process the fact that you need to read from in a particular sequence, in a particular order. That concept is not there. Spelling is far worse than reading. So early markers, they will have trouble learning nursery rhymes. There is lack of interest in playing games with language sounds like repetition, rhyming. So if you look at these symptoms, these are very common things that every child does. So automatically the parents will observe and come to you. So you have to again need a very, very high index of suspicion and low threshold to evaluate these children. Baby talk, mispronounced words, trouble remembering names of letters, numbers and days of week, again in an age appropriate manner. Difficulty with confusing words that sound alike, B, D. Trouble learning to count, write name, letters, unable to recognize phonemes, which word sounds like cat among man, car and dog. So as you can understand, phoneme is basically phonemic awareness, the awareness of a sound. It comes automatically to us, so we take it for granted. So suppose cat, bat, we know they sound same, but a child with dyslexia or specific learning disability won't be able to perceive the fact that cat actually sounds like bat and not like car, because according to them CA is common, so they get confused in these type of processing. So Indian experience, difficulty in writing, inattentiveness, difficulty in mathematics, hyperactivity, reading. This is, you can see, various proportion. All children had poor school performance and up to 30% may have class retention. Why it is important to identify this entity is, with appropriate intervention, they undergo significant improvement and actually can normally attend school and do everything. And because they get frustrated, at times may they have withdrawn behavior, they may have aggressive behavior. So what are the intervention? The intensive targeted treatment to develop phonemic awareness, phonics and fluency. So these are all very subjective. So you have reading programs, individualized remedial reading session. So you can have slightly modified exam system for them, that is from language based tests, we can move to non-language based assessment like MCQs, drawings. They must be encouraged to nurture other talents so that they'll stay motivated. They feel confident about themselves. So the remedial education is the mainstay of treatment, should ideally begin early when child in primary school. So there are special educators. So who are special educators? So they are present at school who would help these children with special needs, these differently abled children, be it ID, be it ADHD, be it LD. So there are special educators who help them, cope up with their academics and other curriculum, and they have individual education program for each child. They have hourly sessions twice or thrice weekly. Concerns are, there is a lack of trained special educators in our country. Parents prefer private tuition, do not want to avail the accommodation. But then these are improving with each passing year, with each passing day. These things are improving in our country as more and more people are becoming aware. We have more special educators now. Many parents have become special educators. So this has led to significant improvement in condition of these children. So what are the accommodations and modifications? You can make the child sit in front. You can change the assignment that is given to that particular child. As I already said, you can prefer non-language assessment like MCQs, oral examination, reading of question paper. You can allow certain amount of spelling errors because this is not something which is within the control of the child. This is happening because the child has a pathology. So you can give this allowance so that they stay motivated. At the same time, you can work with them so that they improve, and so they go on improving with the interventions. So modification in instructional level. For an example, if somebody is poor in maths, so you can give a second grade maths to that child who is in 5th grade so that he stays motivated, he understands the concepts, and with extra effort he gradually picks up. There are other provisions like provision of a writer, reader, extra time. A second language can be exempted if they have problem in language. Then you can add work experience subjects like typewriting, computer, then bookbinding, embroidery, drawing, painting, so that they can develop vocational skills, other skills, and you can find that maybe good in something which other children are not. So that will help him in taking future vocational decisions as well. Strategies for classroom. So repeat and summarize oral lecture notes, key points, verbalize, reading aloud, copy of book list, then computers, record the lecture, flashcards, pictorial depictions always help. You can use multisensory approach, visual, tactile, auditory, kinesthetic. So what happens? And at the same time, model, practice, check, pause, prompt, pace. So what is happening is you are developing skills by which you can help the child improve his or her skills, and at the same time go on motivating, because these children eventually improve. So advocacy, what do the government of India do? So there is extra time for all written tests with spelling mistakes being overlooked. There can be writer for children with dysgraphia. A second language is exempted and it is substituted with a work experience subject. Maths can be modified according to the child's needs. So now the concerns are that there is still lack of awareness in a large majority of Indian schools, but it is improving with time. It was not diagnosed as disability, but now it has been diagnosed as a disability by the government of India. And the need of the hour are trained teachers, resource rooms, educational aids, flexible curriculum, evaluation methods, which is developing now with the government of India. Identifying LD as a disability, this is improving with time. National policy has also come up. So Sarva Shiksha Abhiyan has included LD as children with special needs. So Sarva Shiksha Abhiyan is that every child has the right to read and write and go to a normal school, be it a cerebral palsy, intellectual disability, ADHD, SLD. The school needs to make the arrangements for the child to come and sit and get used to. There comes the role of special educators. So this is Sarva Shiksha Abhiyan. So teachers, training, use of funds, curriculum alterations, we've already spoken about these. So that's it. So to summarize, we talked about three conditions today. One is intellectual disability, one is attention deficit hyperactivity disorder, one is specific learning disability. All these three diseases, the parents may just perceive as poor academic performance and come to you. Whereas a child with intellectual disability will have low IQ. A child with ADHD and SLD won't have low IQ. ADHD and SLD will both have IQ more than 70, some places mention it as 85, and they will have specific behavioral patterns in ADHD and fulfillment of diagnostic criteria. Similarly, specific academic challenges in LD and fulfillment of diagnostic criteria. Early pickup important in all three. You need to rule out treatable conditions like hypothyroidism, lead toxicity, iron deficiency, vitamin B12 deficiency, and the early you pick them up, the early you put them on a rehabilitation program, more chances of they improving further and reaching their maximum potential. Very important to identify and separate LD and ADHD from ID, because LD and ADHD show very good outcome if treatment is initiated appropriately and in a timely manner. And other important thing is that all, not ADHD, but LD and ID at this point of time are known as disabilities, and children with intellectual disability and specific learning disability may get disability certificates. They can avail all the benefits that the government of India gives them. And it is also important to identify the comorbidities that these children have, not just the primary disorder, because holistic management, multidisciplinary care involving which leads to improvement in all the comorbidities would lead to better outcome in these children. So that's it for today's class. This is basically to give you an idea what these three conditions are. You may not know the details at undergraduate level, but when you have finished your MBBS, you should be knowing how a child with intellectual disability will be different from a child with ADHD, will be different from a child with learning disability, and what are the diagnostic and treatment implications. Thank you. That's it. So if you have any queries, you can post them here. Okay, so Aranya, just can you write here whether I am audible or not? Am I audible? If you can just write that yes, you are audible, then I can continue with the discussion. So the point is that, just a second. A child with ADHD, as you saw in the diagnostic criteria, that ADHD needs to be, the behavior has to be developmentally inappropriate. Now suppose you have a child who is 7-year-old, but his IQ is say of that of a 3 or a 4-year-old. Now with an IQ of a 3 or a 4-year-old, if he is showing features of ADHD, that doesn't label him as ADHD. That he is showing because he has ID, intellectual disability. So you may say that with intellectual disability, he has features of inattention, he has features of hyperactivity, he has features of impulsivity, but we won't be able to label him as ADHD using the DSM-5 diagnostic criteria, because that is developmentally appropriate behavior. He is developmentally only 3 to 4 years old, and according to that age, even at 7 years, that behavior is appropriate. So in a child with ID, you already have a situation which is developmentally appropriate. So what I am trying to say is 7 years old, developmental age 3 years old, having features of ADHD. So according to your criteria, he is 7, more than 6, so we can label him as ADHD. But it also mentions developmentally appropriate. He is not developmentally appropriate. He is only 3 to 4. So if at 3 to 4, whatever behavior he is showing is not normal for a 7-year-old. So that is the reason that children who have intellectual disability, they will automatically have a developmental age which is less. So their behavior cannot be labeled as ADHD, because in ADHD the behavior has to be developmentally inappropriate, and somebody whose mental age is 3 to 4 years, the behavior of a 3 to 4-year-old won't be inappropriate. So suppose you have somebody who is 7 years old, otherwise he is smart, goes to school, but there he has these behavioral issues and has similar behavioral issues at home. So his development is fine, his mental age is 7 years, but the behavior is developmentally inappropriate. So that is why ID and ADHD diagnosis cannot coexist. But yes, a child with ID may have features of inattention, hyperactivity and impulsivity. So is it clear to you now? Is it clear, or you need further clarification? Okay, thank you. Anyone else? Any other query? Or we can call it a day otherwise? I'll wait for 3-4 minutes and then we can call it a day.